areas of interest is substance abuse in junior high and teenage adolescents. Our first speaker today is Gina Glass, PA-C M.S. Physician Assistant at the University of Iowa Carver College of Medicine, Workers' Health Clinic in Iowa City, Iowa. Ms. Glass graduated from the University of Iowa Physician Assistant Program in 1982 after receiving her undergraduate degree in zoology. She went on to receive a master's degree in preventive medicine from the University of Iowa College of Medicine. She has been practicing full-time as a physician assistant for over 27 years, the last 15 of which have been in the Workers' Health Clinic. Gina also worked part-time for the last 15 years providing medical services to the residential clients at the Mid-Eastern Council on Chemical Abuse in Iowa City, Iowa. Gina is active in medical education and participates in the training of PA and medical students, residents, and fellows. She is a nationally recognized speaker on many occupational medicine topics and has a special interest in the detection and management of patients with substance abuse, treatment of musculoskeletal injuries, and the prevention of delayed recovery. Our second speaker is Jill Liesveld, M.D., Clinical Associate Professor of Psychiatry at the University of Iowa College of Medicine. She is a graduate of the University of Iowa College of Medicine and completed her adult and child residency training at the University of Iowa Hospitals and Clinics. She is board certified in psychiatry, addiction psychiatry, child psychiatry, and geriatric psychiatry. She has been serving as the medical director of chemical dependency services at the University of Iowa Hospitals and Clinics, as well as the medical director at the Mid-Eastern Council on Chemical Abuse for the past 10 years. She also participates in the training of PA and medical students, as well as residents and fellows. Now, let's get started.
Thanks, Dr. Kohler. It's my pleasure to begin today's program, and thanks to ACOEM for inviting us to present on this important topic. Trying to advance the slides here. Okay. So if you can stick with us today, we will talk about a little bit of data on the prevalence of unhealthy alcohol use and alcohol use disorders. It is really not going.
When you hit that arrow up and down on the bottom
Right.
left-hand corner, or
Okay.
click on the thumbnail
Got it.
view, there you go.
Excuse me for that, everybody. We're going to talk a little bit about potential consequences of chronic alcohol use, including delayed recovery. And although we sometimes only focus on the injury when we're providing care to the workers' compensation patients, if we can detect and manage alcohol use disorders, we can benefit not only the employee, but also their company to decrease costs. We're going to review some screening instruments that are available for the detection of heavy alcohol use in the office. And then finally, we're going to talk about interventional strategies which can be used easily within the workers' compensation patients with alcohol use disorders. So I've never seen a book such as this. If we had this book available, maybe we wouldn't need today's webinar. But we're not going to be talking about the screening, routine alcohol and drug testing, or pre-employment offer, but rather actually detecting alcohol use in the patients that we're seeing in the workers' compensation patients and then intervening in those patients. So first case study, you're working in a busy outpatient occupational medicine clinic. A 27-year-old male construction worker is brought in with a new back injury. This is his third work injury in the past year, and his previous two injuries have resulted in delayed recovery. So the questions you might ask as you look at this patient are, should occupational medicine providers consider substance abuse in their workers' compensation patients? How common is alcohol use in the workforce today? When should you suspect alcohol use? How can we as occupational medicine providers screen for alcohol in the workers' compensation patient? And then finally, if we do detect it, what do we do once we identify it as we're caring for a patient with a work injury? So first of all, why would we even consider alcohol use disorders in the workers' compensation patient? This is a very important area. Heavy drinking several hours before work can impair job performance, and in fact, up to 47% of industrial accidents have been linked to alcohol. 10 to 20% of U.S. workers who die on the job test positive for alcohol and other drugs, and alcohol and illicit drug use prior to work can also impair job performance, leading to injury, and often presenting in our workers' health or workers' compensation clinics. Substance abusing workers are up to 5 times as likely to file a workers' compensation claim. So those that get injured and are not substance abusing may not be as likely to file a workers' compensation claim. And then finally, the potential for delayed recovery is much higher in those that abuse alcohol. The mission of the American College of Occupational and Environmental Medicine includes a couple things that I've highlighted here today, including prevention and management of occupational and environmental injury, illness, and disability, as well as promotion of health and productivity. Although we will not be talking about the detection and management of alcohol use disorders as part of a health management program, certainly as someone presents to the workers' health setting, workers' compensation setting, detecting it within that environment also serves to fulfill these missions of the American College of Occupational and Environmental Medicine. Alcohol has well known to be a cause of falls, lacerations, motor vehicle accidents, violence, and a myriad of other injuries. Any result of this can cause someone to be injured on the job and end up in our clinics. There's significant potential productivity loss from alcohol and drug use, including absenteeism, short-term disability, presenteeism, negative effects on working environment, and job turnover. And as mentioned previously, substance abusers are much more likely to have workers' compensation injuries. So the purposes of definition, absenteeism, I think we're all pretty familiar with what that is, the definition being someone is absent from work. But it also can include when someone takes an extended lunch break or extended breaks during the day, early departures from work, or just not being present physically. Alcoholics and problem drinkers have certainly been documented to have problems with absenteeism, often ranging from 4 to 8 times more often than those who don't abuse alcohol. And another study has shown that alcohol use disorders is one of the health risks noted to increase absenteeism up to 40%. I'll note that that last data is from a recent article published in the Journal of Occupational and Environmental Medicine just 2 months ago in April 2009. Presenteeism, I think, is another term that we're familiar with as occupational medicine providers. And in a sense, presenteeism is the opposite of absenteeism, in which the employee does not come to work. The term presenteeism was coined by Professor Carrie Cooper, a psychologist specializing in organizational management in the UK, and is defined by workers on the job but not fully functioning, and reduced productivity due to poor physical or emotional health. It's been shown that substance abusers are up to 1/3 less productive than their colleagues that do not abuse substances, and alcohol use disorders, again in this recent article published in ACOEM, was shown to double presenteeism. Finally, delayed recovery, although not studied as much as other topics we just spoke about, alcohol can certainly delay healing and modulate the immune function It can trigger inflammation and impede healing. And then a huge area are psychiatric comorbidities. Dr. Ragland wrote in the Alcohol Clinical Experiential Research in 2003, did a 5-year prospective study of urban transit operators in San Francisco. He looked at 1,836 transit operators and examined their first workers' compensation claim after they had already undergone a baseline alcohol assessment. Now, obviously, not everyone was always completely honest on their consumption, but this was at least a way to start and look at the incidence of injuries in comparison to the workers' claimed consumption of alcohol. And what he found was by the people who claimed to drink 0 drinks a week had a hazard ratio of 1.0. People who drank 1 to 4 drinks a week, pretty similar, 0.97. However, when they started to admit to drinking between 5 and 9 drinks per week, you can see the hazard ratio increasing up to 1.10, 10 to 14 drinks a week to 1.30, and which stayed steady when they drank greater than 15 drinks per week. So the conclusion made in the study was that drinking off the job can be associated with workers' compensation injuries. So when we're talking about the importance of detecting alcohol use in our patients with workers' compensation injuries, it's not just because they've received an injury while under the influence, but certainly also they have a higher incidence of having injuries in those that drink alcohol. The mechanisms in this can be thought to be included or caused by either hangover, fatigue, drinking before work, etc. There's also a very good website that I encourage you to look at, alcoholcostcalculator.org/business, in which you can plug in the number of employees. In this instance, I've plugged in 100, but if you're working for a company such that I do that has several thousand employees, you can plug in that number, and it will calculate for you the likely number of problem drinkers in the workforce, as well as the likely number of family members of those employees who are problem drinkers. So in this instance, I've plugged in 100 number of employees. So for a company that has 100 employees, they're likely to have at least 9 problem drinkers in the workforce. And of the employees that they have, they're likely to have 12 family members who are problem drinkers. So why do people use alcohol? This says, I drink to forget, which can take for freaking ever when you're an elephant. But in fact, people drink for a variety of reasons. And it's used by most people safely and without apparent consequences. In fact, the Egyptians made wine as early as 3500 BC, and Stone Age beer jugs has certainly established the fact that fermented beverages existed at least as early as the Neolithic period. We recently have in our clinic somebody leaving, and we're all going out to have a few drinks together. Many people do that without a problem. And so what we're challenged to do as occupational medicine providers is figure out when this use of alcohol becomes a problem. And in fact, in this country, we prescribed alcohol during Prohibition, which was from 1919 to 1933. This is an example of the forms which were printed by the Treasury Department and filled at the pharmacy. Hippocrates also identified numerous medicinal properties of wine, which have long been used for therapeutic value. And this is an example of what the prescription would look like, and it was written for all sorts of ailments, ranging from snake bites to disease control. So as we look at and try to define and categorize our patients, there are certain definitions that we must be aware of as we're looking at data. And they're listed for you here on this slide. This is from the Clinician's Guide from NIA, which I hope all of you have had a chance to either download or look at. and which was referenced in your pre-registration materials. So current use is defined by at least one drink in the past 30 days, and current use includes both binge and heavy drinking. Binge use is 5 or more drinks on one occasion or on the same occasion at least one day in the past 30 days. This includes heavy use. And finally, heavy use is 5 or more drinks on the same occasion on each of 5 or more days in the past 30 days. So the National Survey on Drug Use is now renamed, and they go out, they call it the National Survey on Drug Use was previously the National Household Survey. And it's published every year in the fall. The most recent data is from 2007. And it shows that current drinkers in the U.S., and I want to point out that this is age 12 or older. So they go out and they do household surveys, and persons age 12 or older, current drinkers are just over 50%, or 127 million. Binge drinkers in this country are 58 million, and heavy drinkers are 17 million. And again, this is by the definitions that have just been talked about. So current drinkers is 51% of the population, binge drinkers is 23% of the population, and heavy drinkers is 6.9% of the population. So how about employment status of those alcohol users? Again, from this same survey, you can see that approximately 3/4, or 79.4% of binge drinkers and 79.6% of heavy drinkers are employed either full or part-time. So I hope I'm beginning to paint a picture for you that this is certainly an area where we can start to assess employees for drinking problems outside the spectrum of just prevention, but also when they present for workers' compensation injuries. So when you look at the workforce itself, what is the prevalence of alcohol use? Again, from the same survey, current use ranging from 62.8% of those employed full-time, 30.2% of those employed full-time are binge users, and of heavy use, 8.8%. What industries are most affected by the higher prevalence of alcohol? When I ask this to live audiences, most people come up with construction and mining, but leisure and hospitality industry is also high prevalence of about 15%. The lowest is us in healthcare at about 5.4%, with medium prevalence in comparison to others of finance, retail, trade, and manufacturing. So Dr. States from Boston University School of Medicine wrote an excellent article that I would encourage any of you to download and read. This is one of the graphics that he used in his presentation, and he actually talks about a spectrum of alcohol use, extending all the way from abstinence and low-risk use, which are the most common patterns of alcohol use, to risky use, problem drinking, harmful use and abuse, and finally, alcohol dependence and alcoholism. Now, when I was in medical school, or PA school within the College of Medicine, what I was really hearing a lot about was this alcohol dependence and alcohol abuse. I rarely heard anything, if at all, about problem drinking and risky use. So identifying these issues prior to when it becomes a problem of alcohol dependence and alcohol abuse is a unique opportunity we have to try to intervene before the disease progresses. So we're going to look at a case study right now, and back to the case study number 1. The further history on the injured construction worker reveals that he drinks on weekends. Upon questioning, he admits that this averages a 6-pack of beer each day on Friday, Saturday, and Sunday. So as you hear this history from your patient, you need to determine whether or not this is a problem. So by definition, and again from NIA, at-risk or heavy drinking in men is drinking more than 14 drinks per week or 5 or more drinks per occasion. In women, it's drinking more than 7 drinks per week or more than 4 drinks per occasion. And in the elderly, it's the same as in women, 7 drinks per week or 4 drinks per occasion. So this would actually correspond to this at-risk drinking that we talked about back here. So again, identifying at-risk drinking can serve to allow you to intervene before large problems occur. So why is there a difference between men and women? Again, when I'm speaking to live audiences, what I often hear from people first, and it's true, is that there is a lower body mass index. Women, in comparison to men, on average, have a lower body mass index. But as a result of this, they have a proportional decrease in their weight and their fat weight with less body water to distribute the alcohol. But more importantly, they also have less stomach metabolism of alcohol due to less ADH activity in the gastric lining. This therefore allows women to build up higher levels of alcohol within their blood for the same intake of alcohol. Of interest, this lower ADH actually is even less activity at the time of ovulation. So what is the standard drink? Many times when I'm asking my patients how many drinks they have, they'll say, oh, 1 or 2, 1 or 2 on weekends, or, but what is a drink? To some people, at least in the college towns where I live, 40 ouncer is typical on Friday evenings, especially on happy hours. So clarify how many ounces what their beer is that they're talking about. Defining the standard drink is really 14 grams of ethanol. And by looking at this chart, which is also included in the written materials of your, if you download or order the Helping Patients Who Drink Too Much guide, you will get a really nice version of this. Also included in that is this same chart in the pocket guide for alcohol screening and brief intervention. So please note here that it's not just 12 ounces of beer or a wine cooler, it's also a 5-ounce glass of table wine or 1.5 ounce of 80 proof distilled spirits. So a pint would have 9 drinks and a fifth would have 17 drinks. So what is the drinking pattern within the United States? And this is also taken directly from the clinician's guide, and it says that for those people who never exceed the weekly limit, the percentage of adults with that is approximately 72%, and the prevalence of that person going on to an alcohol abuse or dependence is fewer than 1 in 100. People who exceed only the daily limit, about 16%, and this is about common as 1 in 5, or about 20% of the population. Those who exceed both the daily and the weekly limits, about 10% of people in the U.S. have this drinking pattern, and this is where it gets really interesting, because almost 50% of your patients who exceed both the daily and the weekly limits, as we've previously defined a couple slides back, will have 50% chance risk of going on to alcohol or abuse or dependence. And this is even higher risk in those who have a family history of substance abuse. So what are the clinical indications for screening? Really, any routine examination. Certainly we're seeing people in the urgent care or ER type setting. Anybody who's a smoker, because there's a higher risk of having them go on to alcohol use disorders. And certainly young folks should be screened. And if we're putting them on any kind of medication that is mood altering, we certainly should also be screening. But I would encourage you to screen all your patients. Also, there's alcohol-induced health problems or illnesses not responding to treatment as listed here on the slide for you. Of note to the workers' compensation clinic would be those with depression or anxiety, those with trauma, or chronic pain. In this country, we've heard about don't ask, don't tell for other issues, and unfortunately, don't ask, don't tell within the alcohol screening can certainly lead to problem, and screening for alcohol consumption within the healthcare setting is less than 50%, which can lead to inaccurate diagnosis, inaccurate or inappropriate treatment. It can lead to drug interactions, potential surgical complications. Unexpected withdrawal can occur when someone's admitted to the hospital, and certainly lost opportunities for prevention. So why don't we ask our patients? I think a lot of times it's because we don't think we have time. And of note, for the last couple of years, you can actually bill for alcohol screening under the code listed on this slide. But I think larger than the time issue is that a lot of us are uncomfortable about asking, or may have assumptions about the patient. There's many of us also that just forget to ask. Of note, those who smoke and drink alcohol, there's a high correlation of having both those addictions. And in fact, 70% of alcohol smoke heavily versus 10% of the general population. And I know in the workers' compensation and in the occupational medicine setting, we're often addressing and asking about smoking, and why shouldn't we about alcohol? So in the stages of evaluation, first we have screening, then you can go to assessment, and finally we can refer on for treatment if we do detect that in our patients. So screening for alcohol use disorders can really encompass interviews, questionnaires, laboratory tests, and physical exam. And we're going to cover the first three of these: interviews, questionnaires, and laboratory tests on this webinar. As the U.S. Preventive Services Task Force has suggested, we need to initiate the discussion on all our patients, follow up on positive leads, and certainly be sensitive and non-judgmental when asking. This is the guide that I've been talking about throughout the presentation. Anybody can order this. You don't need to even be a healthcare provider. It's available free off their website, and it's in your reference materials for this talk. Interestingly enough, I use this with all my medical students as they rotate through our clinic, and they use this guide that I have just checked here, this little pocket guide, routinely, and I often run into them a few years later and they still have it, so that, you know, it's a very practical thing to have. There's 4 steps within this guide. Step 1 is to ask. Step 2 is to assess. Step 3 is to advise, and finally, step 4 is to continue support. So we're going to go through a couple pages of this and actually see how it works for you. So this is on page 4, which is asking about alcohol use. The pre-screen for this is actually, do you sometimes drink beer, wine, or other alcoholic beverages? Ask about the heavy drinking days if the pre-screen is positive. So if they say they do sometimes drink, ask about how many days they drink heavily. And what that is 5 or more drinks a day for men or 4 or more drinks a day per women. And once again, you'll recognize that. We had that a few slides back of telling, you know, how many ounces it is for beer, wine, liquor, etc. You can also just leave the audit or have your nursing staff or other staff issue them the audit where they fill out, and that's available in this guide on page 11. There's also a Spanish translation found on page 12. So if the screening is positive, which is 1 or more heavy drinking days, or the audit score is positive, which is greater than 8 for men or 4 for women, if it's not positive, then you want to advise your patients to stay within the drinking limits that we talked about previously, especially if they have a history of alcohol use problems within their family. recommend lower limits of abstinence if you're putting them on certain medications or if they have certain health conditions or obviously if they're pregnant, and rescreen whenever they enter your clinic for a new problem. I don't do it on return visits, but I do for new problems. Now, if the pre-screen if the screening is positive, then what you want to do is you want to find on average how many days a week they have an alcoholic drink, and on a typical day, how many drinks they have for the weekly average. And that is what you need to record in the medical chart. I don't know how many of you guys have seen this. You've seen occasional, oh, I drink just socially. Well, drinking socially to somebody who's an alcoholic, maybe drinking a case a day on the weekends. Drinking rarely, it's really funny when someone says they drink rarely, if they drink a lot, and drinking rarely to them is actually, a couple days a week, 3 or 4. So really define this, and the way I do it in my medical record is I say the patient states they drink, quote, occasionally, unquote, which they define as, and I go on from there. If someone says they don't drink at all, please address why they don't drink. Sometimes you'll find, oh, well, yeah, I really do drink a few drinks here or there. Also, you might find that there's a history of alcohol abuse in either them or their family, and you can be supportive of them. So with that, I'm going to turn this presentation over to Dr. Liesveld for her section, and we'll again, remind you to put in questions so we can address those at the end of the presentation. Thank you.
So as Gina had mentioned, if the screening is positive, it indicates that further assessment is warranted. So now let's move on to the assessment part of things. First, you should determine if there is a maladaptive pattern of alcohol use causing clinically significant problems. So on page 5, the top part of that is for alcohol abuse. And it's really important as a clinician to distinguish between alcohol abuse and alcohol dependence. So for alcohol abuse, within the past 12 months, you should ask your patients if they've had recurrent risk of bodily harm. That would be things such as drinking and driving, operating machinery, things like swimming. Have they had recurrent relationship problems, troubles with family or friends? Have they had significant role failures? Have they not been fulfilling their parental responsibilities at home, their spouse responsibilities, those sorts of things? Maybe they've been less productive at work or have missed work because of drinking. Or perhaps they've had some school-related problems with decline in academic performance. Have there been recurrent legal troubles, things such as OWIs or public intoxication? So if they answer yes to one or more of those in the past year, most likely they have alcohol abuse. If they don't answer yes to any of those, you should still proceed to assess for possible alcohol dependence. So the bottom half of this particular page assesses for alcohol dependence, and this would be page 5. So once again, we're going to be looking at mainly the past year's pattern of drinking. So has your patient not been able to stick to their drinking limits? A lot of my patients will have good intentions. They want to cut back to maybe, say, 1 or 2 drinks a day, but they just repeatedly go over their goal. So that would be a criteria in assessing for alcohol dependence. Maybe they've had repeated failures to try to cut back or stop on their drinking. Tolerance is very common in alcohol dependence, and this means someone who needs to drink more to get kind of the desired buzz or the desired effect from drinking. Withdrawal symptoms are also very common in alcohol dependence. So most folks who are truly dependent on alcohol, if they try to cut back on their drinking or if they stop drinking cold turkey, most of them will develop some withdrawal symptoms, usually within 8 to 12 hours after stopping drinking or cutting back. So withdrawal symptoms, things like tremors, diaphoresis, nausea or vomiting, anxiety, a lot of trouble sleeping during the withdrawal phase. And then has your patient kept drinking despite knowing that it's causing problems for them, whether they be physical problems or psychological problems? Is your patient spending a lot of time drinking or thinking about drinking or recovering from the effects of drinking? Or has your patient spent less time on other parts of their life? Are they spending less time in their leisure activities because of drinking? So if your patient answers yes to 3 or more of those in the past year, most likely they have alcohol dependence. So determine if your patient meets criteria for alcohol abuse or dependence. If no, they still are at risk, so you would proceed to steps 3 and 4 for at-risk drinking. If they do meet criteria for either alcohol abuse or dependence, then you would move to page 7 for the alcohol use and disorders section. So let's move on to another brief case study. So let's say you've obtained some laboratory tests as part of your evaluation of your workers' comp patient who presents with a cellulitis after sustaining a laceration at work. He denies use of any alcohol or drugs, but on routine blood work you discover that he has a high MCV, elevated LFTs, and a very elevated HDL. He denies exercising. How would you evaluate your suspicions? You know, this actually is a fairly frequent problem. A lot of times labs are drawn for another reason, and then labs come up where you might be suspicious for alcohol problems. The diagnosis of alcohol use disorders is primarily clinical in nature, with the patient's history being the key to the diagnosis. Lab findings can provide supportive data, but they're not going to be kind of your primary thing that they're using to diagnose your patient. Just like the physical exam, no abnormal test needs to be present to confirm the diagnosis. The absence of evidence is not evidence of absence. And many patients that drink heavily for long periods of time may have totally unremarkable labs. And many patients, when you are obtaining your history, honestly may not know how much they drink, or they might not be completely truthful. Certainly a hallmark of addiction is denial and minimization. So sometimes your history alone won't give you a good idea to make a firm diagnosis of an alcohol use disorder. And that's where laboratory tests can come in handy to help supplement the interview. Clinical lab tests can also help you identify possible health problems. The thing to keep in mind with these tests, though, they're not necessarily specific for alcohol. So you have to keep that in mind. Clinical tests can sometimes identify heavy use. Abnormal lab tests typically are more common in older drinkers after years of negative health effects from their drinking. Lab test results are less likely to be abnormal in younger people, even though they may be drinking heavily. So use labs in screening to help confirm your suspicion of alcohol problems, and also labs can be used to monitor for abstinence. Some states permit employers to develop mandatory drug and alcohol testing procedures that take effect when a work-related accident occurs. There is a lot of variability, though, from state to state. So it's important to know your state's policy regarding alcohol testing in the workplace. In some states, for instance, if blood alcohol level is 0.08 or greater during the time of the accident, workers' compensation nor the employer is constrained to pay for medical treatment or wages lost. So your patient may lose their workers' compensation benefits if there is documentation that they were legally intoxicated during their work-related accident. So let's move on to talk about some tests that might be helpful in the setting of trying to diagnose an alcohol use disorder. Certainly, blood alcohol concentration can be very helpful. Some workplaces will require a suspected employer under the influence to have a blood alcohol test. Certainly, the blood alcohol concentration is going to depend on how much the patient drank and how long ago they drank. It uses gas chromatography, and it's very, very specific and can detect very low limits of alcohol in the bloodstream. Some work sites may also use breathalyzers, but I think blood alcohol is more commonly used than breathalyzers. There are several biomarkers that we use for alcohol use and abuse. The top four on this slide are indirect markers. So AST, ALT, GGT, and MCV are all have all limited sensitivity and specificity. The carbohydrate deficient transferrin there on the bottom of the slide is more specific and sensitive compared to the other four. So keep that in mind. GGT may be increased with heavy alcohol consumption. It's generally elevated after 4 to 8 weeks of chronic drinking of 4 or more drinks per day. And GGT is elevated in about 2/3 of long-term heavy drinkers. And it reflects both liver damage and enzyme induction due to heavy drinking over extended periods of time. GGT can be useful for monitoring abstinence from alcohol, as it usually takes about 4 to 5 weeks of abstinence for GGT levels to return to normal range. Another nonspecific test that we commonly use is MCV, or mean corpuscular volume. It's an index of red blood cell size. MCV elevation is actually a relatively late manifestation of alcoholism and typically increases with excessive alcohol intake after about 4 to 8 weeks. The elevation is due to both direct toxic effects of alcohol on the bone marrow and also to disruption in folate metabolism. The MCV elevation may actually persist for several months of abstinence. So it's really a pretty poor indicator of recovery in alcoholics. And it's thought that about a quarter of patients with alcoholism will have an elevated MCV. A more specific test for diagnosing alcohol use disorders is the carbohydrate deficient transferrin. It was a biomarker approved by the FDA in 2001 and has been shown to be better than others used previously. It's a glycosylated form of transferrin, and less than 60 milligrams per liter is normal. 60 to 100 indicates probable alcoholism, and anything over than 100 indicates that there's a very high probability of alcoholism. And CDT will be elevated from drinking 6 drinks a day for at least 1 week. And then typically levels will decline by about 50% per week with abstinence, and they will normalize in about 2 to 3 weeks. Keep in mind that CDT will be a little less sensitive in women and adolescents, and that it can be a very useful test even if GGT is normal. A couple of other specific tests for diagnosing alcohol problems are ethyl glucuronide and ethyl sulfate, so ETG and ETS. These are direct analytes of non-oxidative breakdown of alcohol. They're both highly sensitive with unknown specificity, and they can detect as little as a single drink. It is somewhat unclear still what incidental exposure will cause a false positive. The cutoff for these is 100. 500 to 1,000 could mean that there's a possible false positive, and anything over 1,000 means that there's a pretty good likelihood that your patient has consumed alcohol within the last 3 to 5 days. A lot of monitoring agencies are actually using ETG urine testing. Agencies such as your Board of Medical Examiners and impaired professional programs typically will use ETG, particularly on Monday morning urine drops and after holidays. I have followed a few physicians that most likely had false positives. One of my docs was using Avogard hand sanitizer as part of his practice, and most likely was coming up with false positive ETG from that. I had another doctor that had a level, I think it was around close to 1,000, and in kind of further questioning him, this happened kind of around Valentine's Day, and what he had done, he had gotten a special nice-smelling aftershave for his wife on Valentine's Day, and that most likely caused a false positive with his ETG. So hopefully he got something more out of using that aftershave than just a call from the Board of Medical Examiners. Another specific test that isn't used a lot clinically yet is phosphatidylethanol, and it detects 3 to 4 drinks a day for a few days. Once again, it's highly sensitive with unknown specificity. Not a lot of research has been done yet with this, and it really is just beginning to become commercially available. So all of these tests really have varying times of detection, from hours, looking at blood alcohol concentration, to weeks with things like CDT and the liver enzymes and MCV. The urine ETG will typically detect alcohol for about a 3 to 5 day period after consuming alcohol. So you can see that blood alcohol really is not a very reliable determinant in figuring out whether or not your patient is chronically using alcohol. There are a lot of other laboratory findings that are associated with possible heavy alcohol use. For instance, uric acid is elevated in about 10% of patients with alcoholism. Triglycerides are elevated in about a quarter of patients with alcoholism. 14% of patients with alcoholism will have increased bilirubin levels. And then about 20% of patients with alcoholism will have elevated alkaline phosphatase levels. There are also several other common abnormal laboratory findings in alcoholism, such as lowered potassium levels, lowered magnesium and calcium, and lowered phosphate and zinc levels are also fairly common in alcoholism. Finally, if you look at all of these tests individually, there's such a wide range of sensitivity and specificity. So there's a specific test called early detection of alcohol consumption, which really is a panel of routine laboratory tests that a computer program and then a linear discriminant function analysis is done. And really it compares your patient's fingerprint or their lab test to a stereotypic fingerprint of what a light or a heavy drinker would be like. And it's very, very specific for alcohol and actually fairly sensitive too. It does reverse fairly slowly. So in looking back at case number 2, the man with the elevated liver enzymes, MCV, and HDL, you may consider some further evaluation by performing one or more of these other tests. Clearly, your index of suspicion for alcohol problems should be high for him. I think it's always important to try to minimize the harmful effects of drinking with your patients. So you will always want to educate your patients regarding the possible harmful effects of alcohol, especially driving under the influence. Moving on to another case study, a dietary worker comes into your office who has sustained a work injury. As part of her initial evaluation, she's admitted that she drinks 3 beers on Friday nights while bowling with her friends. Your astute interview skills find out that these actually are 20-ounce beers at a local tavern. How would you proceed? So there are actually several things that you in workers' health or workers' comp clinics can utilize effectively. Brief intervention can be very, very helpful. Referring to employee assistance programs can be helpful, and also referring for formal outpatient or inpatient treatment can also be helpful. Brief intervention, really it's not a stop drinking lecture that you're going to be giving your patients, but rather it's a delivery of brief messages that have been shown in clinical trials to have a positive impact on the choices your patients are making about their alcohol consumption. Brief intervention trials have reported significant decreases in blood pressure readings, levels of GGT, psychosocial problems, hospital days, and hospital readmissions for alcohol-related trauma. So really there are 5 A's of brief intervention. We will assess our patient's consumption of alcohol, advise our patients to reduce their use, agree on some individual goals, whether those be to cut back on their drinking or total abstinence, and then assist them with acquiring some motivations to stop drinking, whether they be external or internal motivations. Will help them get some self-help skills, some support to help them with their goals, and refer on to medications if warranted. And then also arranging follow-up support and repeated counseling. Keep in mind that you are in a prime position to make a difference. You don't have to be a board-certified addictionologist, a psychiatrist who specializes in treatment of addiction. You can be very effective in utilizing these brief intervention techniques. And as I said earlier, clinical trials have demonstrated that brief interventions can promote significant, lasting reductions in drinking levels in at-risk drinkers who are not alcohol dependent. Some of your patients with alcohol dependence might not accept referral to addiction treatment programs. Some might. For those who don't accept a referral, repeated alcohol-focused visits with a healthcare provider, primary care provider, or occupational medicine clinician can lead to significant improvement. So let's talk a little bit about the advice and assisting in at-risk drinking where no abuse or dependence is present. So you want to state your conclusion and recommendation very clearly. A simple statement like, you are drinking more than is medically safe. I strongly recommend that you cut down or quit, and I'm willing to help. Now, this might sound just really kind of simple and dorky, but they really are statements, I think, that can make a positive impact on your patients. Consider using the chart on page 25 to show how they are at increased risk, whether they're drinking more than the recommended daily limit or more than the recommended weekly limit, or perhaps both. So show them what increased risk they might have. Also review any abnormal lab results or abnormal physical exam findings with them, because sometimes just seeing that objective evidence can be a strong motivator to help your patient cut back on their drinking. So we also want to gauge their readiness to change their drinking habits. In the addiction world, we have stages of change. A lot of our patients will be in the pre-contemplation stage where they really haven't even considered stopping or cutting back on their drinking. So ask your patient, are you willing to consider making changes in your drinking? Are they ready to commit to change at this time? A lot of your patients, unfortunately, will say, well, no, I don't want to give up drinking. I really don't see it's a problem. I don't need to cut back. I certainly don't want to stop. If they answer no, don't be discouraged. Still have hope that they might change their mind in the future. Ambivalence in addiction is very, very common. So don't give up hope. I haven't given up hope on the Chicago Cubs yet. They lost another one in the late innings last night, but I'm still hopeful that they're going to win a World Series this year. So kind of approach your patients with alcohol problems in a similar vein. Keep at them. Keep hoping that your advice will make a positive change in and of itself. And with some continued reinforcement, your patient may decide to take some action in the future. So don't be discouraged if they're not ready to make changes at this particular point in time. If your patient is ready to change at this time, help them set a goal to cut back on their drinking. And, it can be some real specific things. Help them agree on a plan. So I have a patient that's actually been sober a couple years now, and she made a very simple change in her behavior. She used to, every day after work, drive by a bar on her way home. She would stop at the bar and typically would become intoxicated. She made a simple route change on her way home, and early on in her recovery, I think that was really a key for her to commit to that change. So she would drive home a different way. And she's been sober now 2 years. She now can actually drive by the bar after, learning some ways on how to deal with her relapse triggers and those sorts of things. Advising your patients maybe to measure their drinks at home, alternating alcoholic with non-alcoholic beverages. So if they want to have a root beer instead of a beer, those sorts of things can be very helpful for your patients also. It also can be helpful for them to do things like have food in their stomach when they are drinking. That will help absorb the alcohol a little more slowly, so they won't achieve quite as high of a blood alcohol concentration. Tell them to kind of pace their drinking, sip slowly, those sorts of things. Typically, it's a good idea to have no more than one drink with alcohol per hour. So if they can have some kind of non-alcoholic spacers in between, that would be helpful for them. So you're also going to advise your patients. Some patients can be helped by kind of tracking their drinking in a diary. So, depressed patients sometimes keep mood logs or mood diaries. It can be helpful for patients that are trying to cut back on their drinking to have a kind of an alcohol diary. And it helps them track how much they're drinking, and maybe certain situations where they're drinking a little bit more, they can kind of track that. It's also helpful for them to kind of manage high-risk situations and try to get them to employ a friend or family, a spouse, non-drinking friends. Let them in on their goal of trying to cut back, and certainly support can be very, very helpful. It's also good to provide educational materials to your patients. There are a lot of good online material suggestions on page 20, actually page 27 in the Helping Patients Who Drink Too Much. So providing educational materials can be very helpful for your patients. So let's go on to an example for a patient who might meet criteria for either alcohol abuse or dependence. So once again, we're going to advise and assist, and we're going to utilize these brief intervention strategies. You're going to state your conclusion and recommendation very clearly. Now keep in mind, for alcohol dependence, our recommendation most likely is going to be total abstinence, so quitting drinking. There are a few patients with alcohol abuse that might be able to be successful with the goal of cutting back on drinking, but for a patient who's truly alcohol dependent, it's unlikely that they're going to be successful trying to control their drinking. So we will be advising our alcohol dependent patients to quit drinking altogether. And once again, you're available to help them achieve that goal. Once again, you're going to review any positive physical exam findings, any abnormal laboratory findings with them. You're going to review the possible health and psychological risks that they will incur if they continue to drink at the level they've been drinking. Negotiate a drinking goal with them, and for alcohol-dependent patients, that goal will be total abstinence. They really need to quit drinking. Abstaining is really the safest course for most patients with alcohol problems. As I said earlier, there might be a subpopulation of patients with alcohol abuse that totally are unwilling to consider the concept of abstinence. So they might be successful at cutting down, and even if they're able to cut down a little bit, that could decrease the possible harmful effects that alcohol is going to have, both on their physical and mental health. For your alcohol-dependent patients, you should consider referring for additional evaluation by an addiction specialist. So be familiar with your community resources. Consider recommending a mutual self-help group a lot of patients initially might be a little resistive to this suggestion. Some people equate AA meetings to a religious organization, and they might be a little resistive to that, but explain that AA really is a mutual help group available for people that have the desire to stop drinking. It has nothing to do with any formal religion. Certainly there are some spirituality components with AA meetings, but if that's your patient's reason for not trying AA, do some education about that. So you might be sitting there thinking as an occupational medicine clinician that brief intervention really isn't my job. But I think you really should consider it as part of your job, because it's really people in primary care, people in the trenches that are dealing with folks with alcoholism on a daily basis. You clinicians have the capability to make some positive changes in your patients' lives. You might think you don't have the training. Brief intervention is just as successful with primary clinicians as it is with board-certified addictionologists. So you don't need formal addiction training to be effectively utilizing brief intervention. And then you might think you don't have the time. Certainly we're all very busy in today's medical world. You can actually bill for brief intervention per 15 minutes. And really, brief intervention doesn't take a long time. It could be typically maybe a 10 to 15 minute session 1 or 2 times initially, and then maybe have them come back for a follow-up visit. And on the follow-up visit, it might be that your patient hasn't made any positive changes. Let's say, for instance, the case number 3 bowler comes back to see you in a month or so, and she's still drinking at the same level that she had been. Once again, don't be discouraged. Change can be very, very difficult for some patients. So continue to be supportive. Continue to, relate that her drinking could be problematic. And in her case, she was drinking, I think, 3 20-ounce drinks per Friday night. I mean, if you look at the standard drinks that Gina had gone over, that's probably over 6 drinks per occasion. So that puts her clearly over the recommended daily limit of drinking. So review that with her. If she does come back and says, gee, I managed to cut back significantly, my bowling scores have really improved, that's great. Reinforce and support her, continued adherence to her cutting back her drinking. So a lot of your patients, obviously, they're going to be resistive to making changes in their lives. This cartoon says, can I keep using alcohol and tobacco if I blend them into my morning health shake? So a lot of your patients will be resistive. They might even bring up something like, well, gee, I read where alcohol is good for my heart or it's good for my mind and those sorts of things. So, certainly if your patient is dependent on alcohol, as I said earlier, it's unlikely that they're going to be able to control their drinking. So just a brief slide on HIPAA privacy regulations and workers' compensation. HIPAA really defers to state law regarding disclosures relating to workers' compensation. And it's a good idea to clarify questions regarding disclosure with kind of be familiar with your local state law, maybe talk with your facilities attorney or your administrator with what you can and can't release. Most workers' compensation claims will let you release anything that's relevant to the claim. And I guess, where it gets a little murky is what's relevant. Is, alcohol use always relevant in a workers' compensation claim? Probably not, but there will be instances where it very clearly could be relevant and could be disclosed. Be familiar with your community resources. I think the number of employee assistance programs has just skyrocketed over the last even 5 to 10 years. So employee assistance programs can be very, very helpful in this regard. Outpatient, inpatient treatment programs, be familiar with what's available in your local area. And then support groups, as I said earlier, such as Alcoholics Anonymous, can be very helpful also. Keep in mind, too, that there are medications that can be helpful. Probably in your role as occupational medicine experts, you won't be actually prescribing these medications, but I think it's good to be familiar with them. So to review some take-home points from today's webinar, alcohol misuse in workers' comp patients may lead to productivity loss due to absenteeism, presenteeism, job turnover, and disability. Practitioners caring for work comp patients have a unique opportunity to screen and evaluate their patients for alcohol use disorders. And brief intervention may be used effectively in workers' compensation patients. There is still a ton of research to be done in addiction. We still have a long way to go to, figure out how to best treat alcohol and other substance abuse problems. So, I think also decreasing negative stigma for addiction, anything you can do in your kind of primary care or your workers' comp roles can really, really be helpful. I think we have just a few formal questions to satisfy our continuing medical education requirements. So I will turn things back over to Dr. Kohler, and we will briefly review those medications or those questions and then field any other questions from you folks out there.
Thank you, Jill. Our first question is at-risk drinking in women is defined by which of the following? 5 or more drinks per day or greater than 14 drinks per week, 4 or more drinks per day or greater than 7 drinks per week, 3 or more drinks per day or greater than 5 drinks per week, or that final question, 2 or more drinks or 4 drinks per week.
Well, I think the answer to this question is pretty obvious from the webinar. The answer is B, 4 or more drinks per day or greater than 7 drinks per week is defined as at-risk drinking for women. And at-risk drinking correlates with increased risk for medical complications and progression to abuse.
Our next question will go to Dr. Liesveld. Which of the following biomarkers for alcohol use and abuse has the highest sensitivity and specificity? AST, ALT, GGT, or CGT?
Well, the answer for this is the carbohydrate deficient transferrin. The liver enzymes have a lower sensitivity and specificity. Certainly in clinical situations, it's going to be more likely that you're ordering and reviewing liver enzymes. Carbohydrate deficient transferrin is probably useful more for monitoring agencies and those sorts of things. It costs about $100 for carbohydrate deficient transferrin. It is reimbursed by insurance, but most likely you'll be ordering more of the LFTs. But CDT is more sensitive and specific.
Our third question is which of the following is true about screening and brief intervention, SBI, for alcohol use disorders? And I'll hand that off to Dr. Liesveld.
Well, just in reviewing all of those choices, I think all of the above would be the correct answer. Clinical trials have demonstrated that screening and brief interventions can promote significant lasting reductions in drinking levels in at-risk drinkers who aren't alcohol dependent. So, I would encourage you in your daily clinical work to, do some screening and brief intervention work.
Now for another question. This will go to Gina and to Dr. Liesveld. Do you ever use the case question in assessing for alcoholism?
This is Gina. I'll go ahead and take that question. I do not use that within my job here at the Workers' Health Clinic. What I do, what we're talking about, is the CAGE questionnaire. And what I do is I usually just start by asking, do you ever drink alcohol? And then if they say yes, then I will go into the how many occasions per week and then how many drinks per occasion. The CAGE questionnaire certainly can be used in some individuals, and if you prefer to use that, there's certainly nothing wrong with doing that. But and the questions on the CAGE questionnaire are: C, have you ever felt that you should cut down your drinking? A is, have people annoyed you by criticizing your drinking? G, have you ever felt bad or guilty about your drinking? And E, have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover, which is the eye opener, or E? If the answer to any of those questions is yes, your patient certainly may be at risk for alcohol-related problems. There's certainly nothing wrong with using this as a quick screening tool, but certainly if you do and you detect a problem, then you certainly need to go on to ask the weekly drinking average so you can head back into the format of the helping patients who drink too much handout.
Now what I would like to ask is a question about suspected alcohol use in a patient. What do you do if you suspect alcohol use disorder because you smell it on the patient's breath and you note tremulence, but the patient denies any use?
Well, that's actually a fairly common problem, and certainly a psychiatrist who works with addicted people. I think obviously you're going to try to get some lab testing. If you smell alcohol on your patient's breath, either do a breathalyzer or blood alcohol. They might be resistive to that, but I think it's certainly good to discuss your suspicions with your patient. Try to do some of those screening and brief intervention type things also. Another thing I wanted to briefly mention, as far as brief interventions, there are going to be some times where you're going to suggest to your patient that they totally abstain from alcohol, even if they maybe aren't, even if they don't meet criteria for alcohol dependence. So some of those situations obviously would be if your patient is pregnant, you're going to recommend that they totally abstain. They might be on some medication where alcohol would be contraindicated, so be familiar with what medications your patients are on, and certainly promote total abstinence if they are on a medication where alcohol would be contraindicated. Also, a lot of times you're going to have patients with either a medical or a psychiatric disorder that can be worsened or exacerbated by drinking. So in those instances, you also would want to recommend total abstinence from drinking. And then obviously, if your patient does meet criteria for alcohol dependence, you should always have the goal of trying to get them to achieve total abstinence.
I've heard that the alcohol consequences are worse in women than in men. Is that true?
I'll go ahead and take that question. Actually, there's a phenomenon in women who drink, which is called the telescoping phenomenon. And what that is, besides the ADH lining in the stomach, is that women certainly experience a more rapid progression to alcoholism, as well as medical complications of alcohol use. And there's a very narrow range between therapeutic benefit and harm in women, with death rates being 50 to 100% higher than male counterparts. For example, in comparison to men, women have a much higher evidence of alcoholic liver disease, and that's where telescoping phenomenon is most evident, with 3 times the risk of cirrhosis. As far as cardiovascular effects, women have a higher risk of cardiomyopathy at lower levels of alcohol. And certainly in psychiatric disorders, all are more prevalent in alcohol-abusing women except antisocial personality disorder. Comorbid depression in women is 30 to 40% higher, and eating disorders is certainly higher in women who abuse alcohol.
Okay, this will be our final question. Do you have to report a patient to a professional board of review if you note alcohol use disorder, such as, say, the nursing board?
That's a good question. What I usually do in my practice, if a nurse or physician has a clear problem with alcohol, and certainly if it's impacted their ability to function as a healthcare provider, I encourage them to first self-report to their impaired professional committee. If there's clear evidence that they do have a problem and they perhaps have put patients in danger, if they're not willing to report, we as colleagues, healthcare providers, whatever, are obligated to report. And even if you have say a physician colleague who you suspect has a problem with either alcohol or drugs, and you suspect that it's impacting their ability to practice safe medicine, you as a colleague are actually obligated to report them to their impaired professional committee. Most states have those, or directly to the board. I would recommend usually going to the impaired committee first.
All right, thank you very much. This has been the webinar on detection and management of alcohol use disorders in workers' compensation setting. We'll send it off to Sandy.
Great. Well, I'd like to thank all of you for your attendance, and thank you to Dr. Kohler as our moderator today, and Drs. Liesveld and Mrs. Glass for your valuable presentation. This concludes today's program. You may disconnect.
Oh, you don't need to disconnect. That's okay. You're out.